Good morning, everyone. I'm Shannon Switkowski, the clinic coordinator for our Cardio-ECHO weight management series. I'll just remind you to keep yourself on mute until you're speaking. Use the chat to put your name, location, and your role so we can record your attendance this morning. I promised I would dress up for Halloween, so here I am. We'll go around the room and introduce ourselves.
I'm Jim Warner, behaviorist and educator.
Goutham Rao, I'm the director of this series.
Jessie Lewis, program manager.
And I'm Rick Carnaccio, I'm the web content producer for the Cardio program.
Okay, Dr. Rao, if you want to.
Okay, thanks everyone. So this morning we're going to talk about the National Academy of Medicine competencies for obesity care. And there's many reasons to talk about this, which we'll get into in a moment. But before we do that, Rick has our disclosure statements. So Adam and Chris are on the call today and may make some comments. So you can read their disclosures. I don't have any disclosures, and Jim doesn't have any either. Next slide. So let's talk about the National Academy of Medicine competency. So this was an initiative from the NAM that began about, I think, 2016 or so, and brought together a number of organizations to formulate competencies in various areas of obesity, training and clinical care. My specific role in this organization is to disseminate the competencies to key stakeholders nationwide for training. So it just so happens, I think cardio can be counted as a key stakeholder. So I get emails from the National Academy of Medicine every few months saying, what have you done to make people aware of the training competencies? And so you were all fulfilling a dual purpose, because I can say, hey, I spoke to the cardio group all across Ohio. So next slide. So after attending this brief session, you should be able to describe the origins of the NAM obesity competencies, why we have them, list and describe a minimum of 5 competencies for healthcare professionals, and provide a minimum of 2 examples of applications of the core competencies in a busy primary care practice, because that's our majority discipline. Next slide. So this, these have been disseminated in many ways. These are the proceedings of the workshop, and you can get this, I believe, for a very small fee as a soft cover book. And it is a collaborative from the National Academy of Medicine called The Challenge of Treating Obesity and Overweight. It was published in 2018 by the National Academy's press as well. So if you'd like to read more explicitly about the competencies, not just for training, but for other aspects as well, you can read about that anytime. Next slide. Also, this is very repetitive, so I don't know how many times I've given this talk. So if you've heard it somewhere else, I apologize, but you can also watch the video, which is pretty much what I'm going to say over the next 10 to 15 minutes. Nevertheless, I think reinforcement is really, really important. Next slide. No, not showing. Okay. Okay, so these are the organizations that were engaged in the development of the competency. So why did this come about? Well, for a number of reasons. So the old statistic from 1999 that shows that doctors don't counsel patients about weight was part of the impetus, and a big part of the impetus in developing competencies comes from Bill Dietz, who is a former director of the Centers for Disease Control, and Don Bradley, who is a family physician at Duke University, who is very interested in social justice issues. Also, Kelly Brownell and his group at Yale have been very interested in discrimination and mistreatment of people who have obesity as well. So a lot of this kind of said, well, look, let's put together some competencies that make sense, and brought together different stakeholder groups. These are the groups that are represented here. My connections are to, this is only a partial list, are to the American Heart Association and the American Academy of Family Physicians. And the other guiding principle in putting these competencies together essentially is that we work mostly in collaborative, multidisciplinary environments. So competencies that are directed only at physicians are not going to help solve the problem of training and better care. So that's why there are so many different associations, from pharmacists to nursing to physicians to dietitians, the Obesity Society, which is multidisciplinary, the YMCA, etc. It was a great privilege to work with all of these people. I learned a lot, for example, about how dentists approach obesity and their perspectives on it, and how they discuss diet and inflammation, things like that. So absolutely terrific group. And the origins include multiple meetings over the course of 2 years. I think we will still be meeting again in Washington, D.C. over the next few months to discuss our progress, but it's an ongoing collaborative that is really perpetuated indefinitely as long as these groups are willing to send representatives to us. So the competencies were developed largely by consensus, review of evidence, dissemination of evidence, multiple teleconferences, etc. Next slide. So here are the competencies. And often the wording behind the competencies is a little bit difficult to understand. So what I provided is just a very simple, sometimes oversimplified example of each of the competencies. So the first one is obesity knowledge, framework of obesity as a medical condition. So we want all of us to understand that this is a medical condition. For example, you should know what a body mass index is, and how to figure out thresholds and other important measures of adiposity, such as waist circumference. So these are competencies, for the most part, that anyone who has any contact with a patient should be familiar with. So it's not just for physicians or nurse practitioners or other providers or pharmacists, or it's for everybody, because this is a major public health problem. So the analogy I often think of is smoking cessation. Everybody, including our patients, know that smoking is unhealthy. However, it's probably to everyone's knowledge to advise patients to quit, no matter who you are. If you're a dentist, that would be a wise thing to do. If you are a pharmacist, if you are a nurse, if you are a public health advocate, these are all disciplines in which that particular competency applies. So let's think about obesity in the same framework, in the broad multidisciplinary fashion I just described. So next slide. So core obesity knowledge, you should know about epidemiology and key drivers of the obesity epidemic. So when asked the question, as an educated healthcare professional, why has obesity gone up so much over the last 20, 30 years? And I throw that question out to my trainers and learners in pediatrics, and they have all kinds of responses. And we talk about the convergence of 3 factors in the late 1980s, which are supersizing and the advent not of video games, but more interesting video games. So when I was a little kid, the video games were available, but they were not interesting and they were very expensive. But in the late 1980s, I think the PlayStation and things came out. So that became a dominant source of play. And also the Atlanta child murders, which some of you may remember, took place then. And there was an incredible fear. So when I was very young, you would just walk to school on your own. If you're 5 or 6 years old, it was no big deal, but that changed dramatically. And so children were much, much less active. Those all converged in 1 or 2 years. And we say, hey, maybe this was a driver. What drives obesity among adults? Of course, it has to do with daily energy expenditure in our occupations, which you can see is declining significantly between 1960 and 2010. So these are just some of the factors that take place. But providing an educated response to that question is what the competency really is. Next slide. Disparities. You should have an understanding of disparities and how they may affect obesity. We're going to talk about this, I think, in a couple of sessions when we talk about the built environment. Of course, there are lots of caveats here. So these are Americans living in communities with 1 or more supermarkets. There's a racial disparity as far as that goes. And you should not only be able to explain that these disparities exist, but perhaps how they may influence obesity rates. Next slide. Interprofessional care, this is something we're going to have an entire session on. The essential skill here, and I pushed for this very strongly, is there's a tendency, both for adult providers and for pediatric providers, to try to tackle this problem entirely on your own. So the pediatricians I work with in a different ECHO series, they're like, oh, I'm passionate about this. I'm going to try to fix this kid and this family entirely on my own. It's not going to work. There is no way it's going to work. You don't have the time or the resources to do it. So interprofessional care is something that we advocate very strongly, an example of which is provided here. So you are working interprofessionally with a dietary or nutrition professional, and you say something like, I'd like to let you know that I've raised Mr. Webb's insulin dose as his diabetes was not well controlled. Please let me know if you plan to make any changes to his dietary plan. Okay, that's the level of interprofessional care that is expected for competent management of obesity, assuming this is a provider who's changing the insulin dose. Next slide. Patient interactions. We've already talked about this. This Bill Dietz is very, very passionate about the language to avoid. And I've written about this. Don't use the word overweight. Don't use fat. Talk about person first language, people with obesity. I'm concerned about your weight and its impact upon your health. Would it be okay if we discuss this? We've talked about getting permission. We talked about opening the door approach, which is one of the competencies. So this is how we would open the door, for example, with a child. This has been done thousands of times. I want to let you know that I'm concerned because your daughter's BMI percentile is 98. Most parents do not know what BMI percentile is. I mean, adults don't even know what BMI is. So naturally, the next question might be, what does that mean? It means that she's at a higher weight than the majority of girls her age. This puts her at risk of problems such as diabetes. Is this something you're concerned about? And we work on this together. So the opening the door approach, either for children, adolescents, or adults, works as well. So these are basic competencies for patient interactions. Next slide. Recognition and mitigation of weight bias and stigma. This is a critical one for all of our learners. And the way that I energize, I think that I motivate people to pursue this is talk about Gina's score. This is a story now, it's 20 years old. It's hard to believe it's been 20 years. But Gina was an adolescent who lived in South Dakota, who came from a very troubled family. Lots of truancy, lots of delinquency, stole a makeup kit from a Walgreens that was worth about $10. The store decided reluctantly to prosecute, so they sometimes do. And at that time, rather than sending adolescents to juvenile detention, she was sent to a boot camp for girls because they had boot camps for boys for a long time. Not a bad thing, it was well-intentioned. So on the first day of the boot camp, the girls were asked to go on a run, which was 2 miles along. Gina was 5'4" and 224 pounds, so she fell very quickly behind her peers. And nobody stopped to see what was going on. The other girls finished their 2 miles in about 30 minutes. Nobody looked to see where Gina was. Finally, some of the camp counselors noticed that she was lying face down on the ground halfway up the trail. Nobody called 911. A couple of the counselors were actually young women from the military, poked her and ridiculed her body. Finally, one of them noticed she was foaming at the mouth, called 911, and she died about 6 or 7 hours later. The reason that this story, this is a story that Dr. Brownell from Yale describes very well. The reason I think it's important is a lot of people feel, well, that's horrible, that's terrible. What if she was thin? I think somebody would have called 911. And so the story kind of makes you sensitive to the bias and stigma that these patients face all the time. So, and that's a really important thing to keep in mind in all of your interactions with patients. Understanding that they almost certainly face this bias, even if they don't describe it. People are often embarrassed to talk about it, but employing strategies to minimize the bias is very, very important. Here's an example of bias that actually is real. It's a real example. I wrote it up in the Competencies book. However, it's something to keep in mind because I saw it happen with a family medicine resident. Slender patient has arthritis, gets a steroid injection. Somebody who has obesity, however, doesn't get the same thing. You need to lose weight. And clearly the physician in this case is like, oh my gosh, I'm not going to be able to find the knee joint. It's going to be a really much more difficult encounter. This patient is generating some negative feelings within me, and I'm just going to advise them to lose weight, take the acetaminophen. So clear example of bias in that case. Next slide. Competencies for patient interactions, accommodating people with obesity. The most important thing, I think, whatever sort of healthcare professional you are, has been shown consistently to be privacy in changing and measurement and that sort of thing. So all of that should be done in a private area, including weighing the patient. We don't actually have that in our clinic, but our patients, the other patients that are in our setting are elderly and have heart disease. So it's not such a big deal, but certainly in any other setting, making sure weight is private. You don't have the medical assistant say, oh, 324 pounds. You don't, it's got to be very, very discreet, written on a piece of paper. Waist circumference, which I think is very important to measure, should be done discreetly as well. That's the number one thing patients want. Next slide. So strategies, next competency, number 9, is strategies for patient care related to obesity. So provide evidence-based care for persons with obesity or at risk for obesity. That's essentially following the guidelines, the few that are available. And number 9.2 is evaluate BMI and other anthropometric measures routinely. You want to measure height and, well, not height, but weight at every visit, and most EMRs will calculate BMI as well. But the one that is missing from all that is waist circumference, which should be measured routinely at least once a year. That's what we recommend in the American Heart Association. It's a much better indicator of visceral adiposity and metabolic risk. So also within this set of competencies is evidence-based strategies such as motivational interviewing and cognitive behavioral therapy. So learning to roll with resistance, whoever you are, whether you're a nutritionist, other healthcare professional. So you don't want to be saying things such as to a patient, it's pretty simple, get to the grocery store once a week and give up fast food. Okay, that sounds like a straightforward recommendation. However, rolling with resistance when people push back means you find it hard. Let me see if I understand you correctly. You find it hard to make the time to shop and cook meals, and therefore you're relying on fast food because it's a lot more convenient. Am I hearing you correctly? So you're rolling with the resistance, but it builds trust and is more likely to be an effective approach to behavior change as well. So next slide. So special concerns, this is the last competency. And as I said, this is a very, very quick run through with some brief examples, and you can read about the competencies in much more detail. So one thing is provide evidence-based care services for persons with comorbidities, but responding appropriately to patients with obesity comorbidities based on scope of practice. And what I think they adopted this competency for was essentially to raise awareness of obesity and its health impact. So this is 8th grader Jamie is sent to the school nurse's office after she struck her head on the edge of a desk, suffered a small bruise. Not a big deal. But the school nurse questions Jamie and reports that she hit her head when she inadvertently fell asleep in class, and it happens all the time. And the teacher just kind of says, hey, you need to wake up, pay attention. And then she starts to talk a little bit more about it and says, I never get a good night's sleep. Her younger brother always complains that she snores all the time. So we're starting to get more and more of the history. So if this is a major public health problem and you are a healthcare professional who is concerned about the problem, you probably should figure out right now that this young girl has obstructive sleep apnea. And the nurse in this case speaks to Jamie's parents, then they seek appropriate evaluation care thereafter. So what is the competency? At least knowing what the range of comorbidities are with respect to obesity and providing appropriate evidence-based care. Next slide. So that is a very, very brief overview of the competencies. As I said, these are skills that we want with some caveats, with some adaptation to profession. So we don't expect, for example, a pharmacist to be able to interpret a sleep study or necessarily, but a range of the skills that everyone should have in the healthcare field as they care with patients with obesity. And I think they're important to disseminate not just to providers, but to everyone in your office. As we get into the sections on collaborative care, I think they become important, where everybody has a specific role in caring for specific patients with obesity moving forward. Okay, Thanks very much. I'm going to stop there and see if there are any questions before we move forward.
All right. Today is the last day to update your contact information. We sent surveys through your emails. We are using this information as a part of our internal evaluation, as well as making a cohort list to share with all of you. If you wish to opt out of sharing your contact information with the cohort, please email me by today. Next slide. Last week we announced we opened registration for our spring 2020 TeleECHO Clinic, which is reducing the burden of hypertension. They will be Thursdays from 8 to 9, January 16th through April 2nd. So that is a 12-week series as well, much the same as this one. So please visit our website to register for that. And if you want materials to share at your institutions, I do have materials, and I have emailed those once, but I would be happy to email those out again. And then finally, we have emailed you the post-clinic surveys. Those do help us. We review them every week. Your comments are valuable. We've addressed several comments individually up to this point as well. So if you do have anything to say, please let us know. And in the end of the series, we'll be sending out myevaluations.com, which is an online site so that you can claim credit if you're interested. So that is coming within a few weeks. So next week, we will have our social, environmental, and cultural influences on weight on November 7th. Stay dry tonight. If you're going trick-or-treating, be safe. Eat lots of candy. Bye.
Bye, everyone. Take care.